Welcome everybody, and it's my great pleasure to welcome you to the 2022 Marian Barrett Lecture. My name is Marie Gertz and I'm the Professor and Head of the Department of Nursing here at the University of Melbourne. We're meeting this evening on the land of the Wurundjeri people, and I acknowledge this place as a site of age-old ceremonies, of celebrations, initiation and renewal. I pay my respect to Wurundjeri elders and their families and extend a very warm welcome to any Aboriginal and Torres Strait Islander people who will be with us this evening, either in person or online. I also extend a special welcome to all our distinguished guests, including Professor Mike McGuckin, who is Associate Dean, Research, Faculty of Medicine, Dentistry and Health Sciences, Professor Bruce Thompson, Head of the Melbourne School of Health Sciences, and Professor Leanne Aitken, Associate Dean, Research, Enterprise and Global Engagement from the School of Health Sciences, City University of London. I also have apologies from Emeritus Professor Judith Parker, who was hoping to come this evening but unfortunately can't join us, but sends her wishes to everybody. Welcome also to our fantastic health service partners who've taken time out from their busy schedules to come along, and our wonderful students and alumni, and of course to all of our staff this evening. A few matters of housekeeping before we start. So please switch off your mobile phones or turn them to silent. You can share your experience on Twitter. We have a hashtag there, 2022 Nursing at UOM. There'll be time for questions at the end, and we'll use a roving mic after Leanne's speech to ask those questions. We also have quite a lot of people joining us online, and they can post their questions in the Q&A tab at any time during the session. Professor Denise Harrison will be mediating those questions. Please stay on and enjoy the networking after. We have drinks and plenty of food, and we know how important it is to all join together at this time where we haven't seen each other in person for so long. So tonight is the eve of International Nurses Day, and each year on the 12th of May we recognise nurses and the contributions that they make to society. International Nurses Day marks the anniversary of the birth of Florence Nightingale, and Florence Nightingale was actually a social reformer. She was a statistician and she was a founder of the modern nursing profession. Through her work, she raised awareness of the public value of nursing, and she championed the education for nurses. She laid the foundation for a discipline with the establishment of her School of Nursing at St Thomas's Hospital in London, which is now part of King's College London. The Department of Nursing here at the University of Melbourne is committed to initiatives led by the International Council of Nurses in partnership with the World Health Organisation to strengthen the global nursing workforce and extend its reach to improve access to healthcare for all communities. Educational uplift of the whole of the nursing workforce is critical to attaining these goals, and so too is rewarding and recognising academic excellence in the profession alongside our nurses, who are often celebrated for their service achievements. Each year, the Department of Nursing awards scholarships and prizes to nursing graduates. Many of these people who are named on the slide here receiving prizes tonight, and these prizes are named after outstanding nurses or people with connections to our university. Tonight I extend my congratulations to both the 2021 and 2022 prize winners, and most of those people are here with us, so thank you for coming along. As part of our International Nurses Day celebrations, we're going to post the stories about their achievements on our website and on Twitter. You can join the conversation on Twitter with the hashtag of 2020 Nursing UOM. I also want to sincerely thank our esteemed benefactors who, through their generosity, continue to recognise excellence in nursing scholarship and in clinical practice. And a special thank you to Ms Alison Hyams and Ms Julie Sheldrake for joining us this evening. And I also want to acknowledge the Royal Melbourne Graduate Nurses Hospital Association for their contribution to our prizes as well. Now for a new announcement. This year, the Department of Nursing, in conjunction with the Centre of Palliative Care at St Vincent's Hospital, is delighted to announce the launch of a new fund to support research in palliative care nursing. The Dame Quinton Bryce Palliative Care Research Fund offers Master of Philosophy and Doctor of Philosophy students the opportunity to apply for up to $30,000 per annum in funding as top-up for their research endeavours. The Dame Quinton Bryce Palliative Care Research Fund is now open, and we're taking applications until the 25th of June, so that's a really exciting initiative, and we thank our colleagues at St Vincent's and to Dame Quinton herself for supporting this endeavour. So now, without further ado, I would like to hand over to Professor Mike McGuckin, who's our Associate Dean of Research, to provide a brief background to the lecture itself and to introduce our speaker for the evening. Thanks, Mike.
Thank you, Marie, and welcome everyone. And I join Marie in acknowledging that the lecture is being held on the lands of the Wurundjeri people and pay my respect to their elders past, present and emerging. This lecture is the result of a bequest that was left to the university by Sir James William Barrett in 1945 in honour of his wife Marian. Barrett made this financial provision for the founding of a School of Nursing at the University of Melbourne via the Marian Barrett bequest in the pricely sum of £750. And the bequest in its original form was not realised and the money was invested. And then it was revived 51 years later in 1996 with the power of a bit of compounding interest, I'm sure, and the School of Postgraduate Nursing was established under the stewardship of Professor Judith Parker. And since 1997, the Marian Barrett Lecture has become an annual event and a highlight of our nursing calendar at the University of Melbourne. And I'm very pleased to introduce our orator this evening, who's Professor Leanne Aitken, who is an Australian nursing clinical researcher who was recruited from Griffith University to the UK, where she is now the Professor of Critical Care and also the Associate Dean for Research, Enterprise and Global Engagement at City University of London. Her program of research focuses on recovery after critical illness and injury and a range of clinical practice issues within critical care. Leanne's also an ambassador for the World Federation of Critical Care Nurses, a Fellow of the American Academy of Nursing, the Australian College of Nursing and the Australian College of Critical Care Nurses, and is also a Fulbright alumnus. Leanne has published more than 150 original peer-reviewed publications, edits the textbook Critical Care Nursing, and has secured more than 23 million Australian dollars in research and research training funding over her career. The topic of her oration on consumer participation in research is something that we do well in places in our faculty, but need to work on a lot to become a stronger feature of our research program. So I, and I'm sure everyone here, will be very interested to learn from your experience, Leanne, in the UK, where this is done much more comprehensively. And it's my pleasure, as I said, to welcome Leanne to deliver this year's Marian Barrett Lecture on embedding consumer participation in research. Leanne.
Thank you, Mike. Thank you to Marie and Bruce for the invitation to join you here this evening. It was lovely to have an opportunity to get back into the country. As you might imagine, it's been a few years since I was back in the country, but it's lovely to be back here and to be sharing the evening with you. So thank you very much. So as Mike said, we're going to be talking about embedding consumer participation in research. And I'm very conscious that there are some areas that do this well. And I don't want to suggest that that's not the case. The difference between Australia and the UK is that in the UK, it is extremely widespread. And you basically can't get research funding without effective consumer engagement or consumer participation in research. And so that's the sort of different setting that we're in the UK. So for a moment, let's think about why we should involve consumers in research. Certainly it's a core democratic right that people who are affected by research have a right and a say in how they experience research and how research is undertaken. And that's from the Involve briefing notes. Involve is the UK guidance on consumer participation. Looking at the NIHR, who published their document in 2016, they talk about involving consumers and community members can add value to health and medical research, and they have a right and responsibility to do so, in other words, to participate in that research. So what is meant by consumer involvement? And you'll see that I chop and change between terms, consumer involvement and consumer engagement. I'm largely using those to mean the same thing. I will also try not to forget, but no doubt will forget. In the UK, this is referred to as patient and public involvement, or PPI. It means exactly the same as consumer engagement here. So forgive me if I slip back into the UK language. But what we're talking about is research carried out with and by members of the public rather than to, about or for them. It includes children and young people, and it's more than simply raising awareness of research or sharing knowledge or creating a dialogue with the public or recruiting patients and members of the public as research participants. So it's not any of those things, it is more than those things. Some of the benefits, if we take a moment to think about the benefits of involving consumers in research, certainly it empowers people by involving them as equals in the work you're undertaking. It gives a different perspective that helps with the clarity of research. It also helps us focus on what's important to members of the public. There's the potential to influence change or have public support of research much more. And it also provides a level of transparency and accessibility that may not occur if we're not involving consumers as our partners. Importantly, it also offers the opportunity to improve the public confidence in research, that they believe that the research that is being conducted is valuable, will lead to outcomes that are important for all of us, and from a health point of view will lead to outcomes that improve the health of individuals across the nation. This was one of the earliest systematic reviews that was conducted looking at the impact of PPI, or consumer engagement, on service users, researchers and the community. And this review was actually published in 2014, so it's getting a bit old now. Obviously, it was looking at all the research that existed before that. At that point, you can see that 2/3 of the research that was included had occurred in the UK, and just a couple of papers or a couple of studies from Australia. But what they found in that review was that they found that service users felt empowered, valued, and gained confidence and skills in participating in that research. They also noted that service users found a lack of preparation and training contributed to them not feeling as if they were able to adequately contribute. And we'll come back to their training in a little while. Certainly some of the service users felt overburdened by the work they were asked to do, and they didn't always feel listened to or valued, and did feel there was a them and us situation at times. So again, things we need to think about when we set up our consumer engagement processes. When talking to the researchers or looking at the evidence in these papers from the researchers noted that they developed greater understanding of impact in their research area, but they also did note difficulties in incorporating meaningful consumer engagement due to time and money constraints, and I will talk about some funding issues in a little while. As an example of some of the work that is done in Australia, this is a paper that was published just last year in 2021 by PC4, which is an Australian organisation that supports clinical trials in primary care, specific to the cancer field. And in 2011, Cancer Australia published a national framework for consumer involvement in studies in the area. And this study was to identify barriers and facilitators to long-term consumer involvement. And what they found was that they identified that committed organisations, in other words, organisations that were committed to effective consumer engagement, had adequate resources and support for the processes, and you can see there that included funding for time, travel, accommodation and training of the consumers to participate. They also provided adequate education and training. They offered appropriate facilitation for consumer involvement, and it was planned appropriately. They noted that capable consumers were people who had consumer experience, so relevant experience, and I'll talk some more about when you consider what sorts of experience. Consumers who were motivated, and they found mentoring of consumers was an important element. They identified that when we had a shared focus, that led to successful consumer engagement and inclusive groups. So that is work coming out of Australia just last year. Now, if we think about what is meant by consumer engagement or consumer involvement, there's really a continuum of what that involvement might consist of. And if you start from your left, that is the most simple of the consumer engagement that's about simply informing consumers. I'm not talking about that tonight. That's less than what I'm referring to. The next three levels of engagement or involvement are about consulting, involving or collaborating consumers. And that's predominantly what I'm talking about this evening. The final area on the far right of the continuum is about sharing leadership, and that's much more about co-production. And so I'm typically not talking about that this evening because that's quite different to the level of consumer engagement that I'm referring to this evening as something that should occur in every project, as distinct from something that you might look at shared leadership of. And I will talk a little more about that just for a moment. This is a UK publication, again from the Involve website, where they do talk about what is co-production and make some distinctions between consumer engagement and co-production. So co-production is where you are working on an equal platform with consumers, and that you're working on something that has been developed all of the way jointly, and that leadership is shared between the two groups of people. Well, there might be more than two groups of people, but certainly researchers and consumers. There'll often be clinicians and other groups involved in that research. So if you look at the image up there, they talk about building and maintaining relationships, reciprocity, sharing of power, respecting and valuing the knowledge of all, and including all perspectives and skills. With the exception of sharing of power, the other four areas all apply to consumer engagement. It's that sharing of power that lifts it up to another level. So just very briefly, you'll see the difference between consumer involvement and co-production, or it's also referred to as co-design. And you'll see that with consumer involvement, the researchers own the research, the public has an advisory role. The primary purpose of the activity is to provide guidance to researchers and improve research. Researchers generally retain the power, but with efforts to address the power differentials. And it's about building and maintaining relationships, respecting and valuing the knowledge of all. Now, I think every bit of health research can have that in and should have that in. And that's the view that I come from. And there's no reason why we shouldn't be including that in every bit of health research. In contrast, co-production is something that will be for specific purposes and specific designs and specific questions that won't be relevant across all areas of research. So if we take a moment to look at some of the resources you might use to help you on this path, as I referred to earlier, there is some guidance from NIHR that was published in 2016, and so that's got certainly lots of good suggestions in it. Some of the important elements are that consumer and community involvement should be a commitment to the involvement of consumers and community members in various levels of research activity that I've just talked about. And we need to consider how to involve consumers. So some of the suggestions that they make are as a member of the institution's governing board, a member of Strategic Research Advisory Group, a chief investigator on a research project or grant application, providing their perspective, consumer perspective, over the cycle of the research project, and providing their perspective on translation of research into patient care. That's by no means exhaustive, but there's some of the suggestions. This video that I'm going to show you now is one of our consumers that's involved in several of my research projects. Bob will tell you a little bit about himself, and for those of you who are online, I'm sorry, I believe the sound is not translating brilliantly to online, but it is fine in the auditorium here. Bob has a reasonably strong but not horrific Scottish accent, so hopefully that translates okay. And you will hear Bob refer to the fact that he's come through the NHS in Scotland. So he is from Edinburgh, and he was in Scotland intensive care. And the NHS, for anyone that isn't aware, is simply the public health system that covers all of the UK. So when he's referring to that, that's what it's about. He will also talk about the fact that he's got a background of project management and how that's helped him in some of his PPI activities with us.
Oh, hi, I've been asked to give you a few thoughts on my involvement with research projects in NHS Scotland. My name's Bob. I was involved in a near-fatal accident 11 years ago, and I've been helping with research projects over the past 6 years. A few things I think that I can help with. I've worked with some brilliant and very capable people on these research projects who know far more than I do, know far more about the technicalities and the science and the medicine that is involved in the research project. So why should I, as a non-technical, non-medical person, be able to contribute anything to a research project? The first thing I would say is a concept called the Tin Man Act, which we used to use in business when we had a problem, when we had something to be sorted out. And basically, the idea was you got somebody who knew nothing about the problem, knew nothing about the project, and you tried to explain that to them. They didn't even need to say anything. But the mere act of trying to explain to somebody a technical problem made it very clear to you as the person who was trying to resolve the problem. So it was called the Tin Man Act. You just sat there, somebody explained the problem or explained their project, and in doing so, it became clear. In fact, often when at the beginning of a PPI project, the sponsor will verbally describe the project, and it's quite simple and it's quite straightforward and it's very understandable. And my immediate reaction to them is, well, why don't you just put that down in writing? Because what you've put down in writing is actually much more complicated, much more technical, much less understandable. So that would be the first thing I would say. The second thing is lived experience. So really, you need to have been through ICU to know what it's like, and that experience can be brought to bear on a research project. So, for example, you have a very complicated consent form for people, then I can chip in and say, well, I can remember the state I was in when I was in ICU and even after it. And this consent form would be very difficult to understand, very difficult to agree to, because there were so much more important things going on. The next thing I would say is my business experience. So I was in IT, principally in project management, and there's a lot of things in that field which are relevant to a research project. The first is clear and precise communication. The ability to say things succinctly, briefly, without any unnecessary descriptions, without repetition, wherever possible. Then there is the question of perspective. So the ability to see the bigger picture. Sometimes if you've got a project or you've got a problem, you get too close to it. Somebody coming in with a patient perspective, for example, rather than a research perspective, can see things differently and contribute ideas that the researcher themselves might not do. Then in project management particularly, there was always the desire to deliver things early. So to break a big project down into smaller phases, and to see if some substantial benefit could be obtained from an early delivery of certain parts of the project. And that was a very successful way of making progress and testing the waters on a project, and delivering benefits to the end user as quickly as possible. And finally, it's getting non-technical, non-medical people involved in a PPI basis helps to make the approach more patient-centered, and in a way closer to reality, because the only people who know about the reality of ICU are honestly the people who have been through it. So that's a few of the things that I think I can help a project with. What I get out of it is the satisfaction of helping the NHS here in Scotland, because they saved my life, they saved my leg, and I'm eternally grateful to them for that. And I feel I have to put something back in as much as I possibly can. And beyond that, it's a question of helping others. So if there's a research project which has an important contribution to make, then if I help that, then I help other people for the future. So that's my thoughts on the subject. Thank you very much for listening. Bye.
So as you can see, even though we asked Bob to be involved because he was a past patient, we got a whole stack of extra benefits of the way he thinks that, brings a different perspective to the project. So some of the things we think about when we involve people in research, certainly as early as possible. I was talking before we started this evening about that's not the week before when you've got a grant due in next week and you need to tick that box. That's 6 or 12 months before you intend putting your grant application in. Think carefully about the different roles and make activities and responsibilities clear. And we do have a brief job description, 6 or 8 bullet points of what we're seeking from our consumers, because when we advertise, we need to be clear what we're asking for from them. Consider the format and frequency of involvement, whether that's face-to-face, email, teleconference, obviously over the last 2 years, much more about video conference. Make sure you resource the consumer engagement appropriately, and I'll talk some more about that. offer training, or we're lucky in the UK, we do have organisations that will provide that training for us. But certainly it's not something that people can automatically do, in the same way you wouldn't expect any of us to know about research without receiving some training in it. So it's about training in the generic principles of whatever you want them to participate in, but also training specifically in the project that you're looking to have them involved in. Provide ongoing support and keep a clear record of consumer involvement. It does need to be in all your grant reports and publications, and I will talk about the publication guidelines for it. So I wanted to share with you a few examples of how we're involving consumers in our research. And so the first one I'm going to talk about is the A2B study, which is a large multi-centre ICU sedation study that's currently being conducted. It's funded about just over $2 million by the NIHR, which is the equivalent of NH&MRC, their Health Technology Assessment Program. And Professor Tim Walsh, who's a Professor of Critical Care Medicine, is leading that. He's in Edinburgh, and I lead one of the work streams within that project. And Bob is one of our consumer representatives on this project. Certainly we've had multiple PPI events through the research cycle. We've got a group of 8 to 12 patients and family members who we meet with about once every 12 months to help us with the next stage of the project. And I remember when we had the first PPI event planned, and I was in London, I wasn't there, but a couple of the co-investigators who were in Edinburgh were holding it one evening, and the forecast for the weather in that part of Scotland was for a blizzard that night, and I thought, okay, well, that's going to be cancelled. I got an email early the next morning saying we had a great PPI event last night, 11 people turned up. They are just so committed that they absolutely drove through a blizzard. It wasn't going to stop Scots people from turning up, was the answer. So certainly at the concept stage, is this topic important? At the detail stage, what are some of the study processes and how can we refine those? Particularly those processes that interact with patients or their family members. Bob, or one of the other members of the group of patients, has come to every ethics committee meeting that we've needed to present at and helped address questions and convince the ethics committee on our behalf that what they're proposing is appropriate. Them speaking for us is much more stronger than us speaking on their behalf. They've also helped during the study to refine some of our outcome measures because we are having some problems with low retention, and I'll speak about that in a moment. Certainly, Bob is the co-applicant on our grant application, so the grant application that went into NIHR, he's a co-applicant on it. We have 2 other members of the group, 1 patient and 1 family member, on our trial steering committee, and so they participate in all of those, and they'll certainly be involved in dissemination. A little bit more detail. So this study was in the UK. They have funding opportunities where NIHR specifies what research question they want addressed, and they call for responses or grant applications to address that question, which is a bit different, I know, to the Australian setting, but they stipulate what outcomes we need to address. So we had to address what was stipulated by NIHR, but on the basis of the advice we received from our consumer group, we added 2 outcomes to that list, and that was the patient's ability to communicate while they're in ICU and being sedated, and some additional measures of psychological function and also the patient experience of being in ICU. And because we argued those extra outcomes on the basis of patient input, the NIHR was prepared to fund them. They wouldn't have otherwise. The things that they've helped refine for us, so they helped us with the sedation care pathway. So this is about clinical care, and they will give their opinion on that. We had big discussions about whether we should be blinding the drugs so that no one would know which of the drugs the patients were receiving. And it was on the basis of the advice we received from our consumer group that we made a decision not to blind. They said, we wouldn't be comfortable with you not knowing what drug you're giving us, and more people will not provide consent if you go down that path. And so it was on that basis we made that decision. We also, what we proposed as the period of time for family members to think about and give consent, our first suggestion to the consumer group, they didn't agree with, and we lengthened that period of consent advice time. As I said, we changed some of the outcomes, and they review all of the study materials that are going to patients and the public. So a huge range of things that they help us with. So who and how to find consumers? Normally we have more than one person so that they're not isolated, and that would be my recommendation. Need to think about whether experience of a specific condition or care is important. So for some things, it's just any experience with the healthcare system. The example I just gave, we wanted people who had ICU experience. Think about the person who I refer to as the professional PPI representative. And there are many people like that, and they're very valuable, but they will be on multiple projects. And after a while, they start to think more like the researchers than a member of the public. Is that what you're looking for? So think about that. So some of the ways we find representatives in the UK, there's a number of general community groups that are advertised on the website where we can find people. We can advertise through various GP and health clinics. Most hospital trusts in the UK maintain a database of interested people so that they advertise, if you'd like to help with any research, please let us know. Some of the specific disease groups have groups. So in my area of intensive care, there's ICU Steps, which is a patient and family member post-ICU group. And we can contact ICU Steps and they will advertise for us and find past ICU patients. The same exists in lots of different disease groups. So certainly social media we've used in the past. And there's also a generic PPI or People in Research website, again UK-based. I'm giving those UK examples so that you can think, are there equivalent examples in Australia? If you're from a hospital or a healthcare service, should you be setting up a database for those sorts of things? So a couple of other examples of our consumer engagement. This is, so Harp Health Advances in Underrepresented Populations and Diseases is a recent doctoral training program that we've got funding for, and the Wellcome Trust is a big philanthropic organisation that predominantly funds in the UK but does fund beyond the UK and I know in Australia. And with partners at Queen Mary University of London, we've recently received just over $8 million to fund a doctoral training program. And given the focus of this, looking at underrepresented populations, it makes sense that there was no way we were going to go ahead without great consumer engagement. If we're wanting to improve the how underrepresented patients and populations and diseases are included in research, we had to be working with our partners. And so we've developed a lay advisory group of 6 to 10 patients, carers and members of the public. 2 of those will sit on our advisory board. We're only just in the process of setting that up. We conducted, the week before I left England, we conducted our first interviews for our future students, and there was a member of the lay advisory group on each of those interview panels. They're going to contribute to the training that we conduct. and they'll be available to consult with all of our fellows on an individual basis. So that's an example in a doctoral training program. As a final example, Duncan Smith is one of my PhD students who's just about nearing completion of his PhD, but he's funded by the NIHR as a PhD studentship. And so it doesn't matter whether you're looking at grants or fellowships for research training, adequate PPI is essential in the UK. And so Duncan certainly had to have effective consumer engagement before he submitted his application and all the way through his PhD. He has 2 patient advisors and he advertised for them through the hospital PPI department as well as through the local ICU, and he also went to ICU steps to get some advice there. And before he advertised, then the PPI manager reviewed all of those materials. That work, the protocol for that work, is published in Journal of Advanced Nursing in 2019. So what Duncan has is one patient advisor reviewing all the study materials and process via email, and a second patient advisor coming in person when that's required. We included in the funding for the PhD training for both Duncan in PPI activities and for one of the patient advisors who wanted that training. The other patient advisor didn't want the training. Certainly they've commented on and been involved in all the study designs and all of the processes for his observation and the things that he's done for data collection throughout. They'll also advise on some of the study dissemination materials that's just going on at the moment. So it's not just big grants, it's small grants, it's doctoral training, it's everything. Within the UK, we're fortunate that the Research Design Service, which is provided by NIHR, does provide £400 for any of us to do PPI before submitting a grant application. So I guess I'd say to those of you who are in the senior roles, be thinking about how you would fund those sorts of activities to encourage people to start consumer engagement before an application goes in. Certainly there's an expectation that all patients and public have their expenses met and are reimbursed for their time. Excuse me. And Involve, which as I said is the guidance for consumer engagement, they provide detailed guidance on what we should be funding. And they have a website that provides all that. People will often, when they're new to this, will say, well, why should we be paying for consumers while they're participating in this and being at our meetings? Everyone else sitting around the table's receiving a wage. Why shouldn't they? Why create that differentiation? Their time is just as valuable as all of our time. Occasionally we'll have people who decline payment, but they should all be offered it. This work is actually a model that comes out of, as you can see, the University of Melbourne and St Vincent's. And that's an example of a local model for consumer engagement that is worth looking at and thinking about. And so that is different levels of consumer involvement in a local setting. So I mentioned that. Some of you might be thinking, well, how do we do this in areas like dementia care, where it's really difficult to sometimes seek the opinions of people who have got dementia or other equivalent diseases that mean consultations inappropriate? This is an example of 20 studies that have been conducted in the EU, 19 in the UK and 1 in the Netherlands. And it was about involving people living with dementia. Most commonly, it was the person living with dementia and their carer involved as a partnership or as a dyad. And you can see the areas of contribution were about identifying and prioritising research, some of the design issues, and how to conduct that research. And you can see they're the same sorts of strategies that I've talked about before. The things to note is that with some populations, like patients with dementia, flexibility is absolutely required. You need to be thinking about different capabilities and different people. And in that population, they noted that long-term involvement was often difficult. So it was much more short-term involvement. I'll just briefly mention the James Lind Alliance, which is an organisation in the UK that funds work for clinicians and patients and public to work together to identify the top 10 research questions in a field. And if you can use James Lind Alliance priorities to guide your research, it's something that increases the chance of funding in the UK. There's nothing equivalent that I'm aware of in Australia, but I would suggest that's something that would be important and we should be thinking about and looking at. So some of the strategies to optimise benefits, and I've spoken about most of these. Make sure you've got training for everyone that's involved. Appropriate funding, plan and develop from the very beginning. Be realistic about what you're asking consumers to contribute and draw on their strengths. Don't go beyond their strengths. Do make sure you establish rapport, outline your expectations and develop a plan for consumer involvement. And as I said, we always try and have multiple consumers so that they're not isolated in a group. As I mentioned right at the beginning, there are guidelines for how you should report consumer involvement in research. They're the Group 2 reporting checklist. So for all of you who are reporting that, you need to be making sure you've got details of how they were involved. A couple of other NH and MRC useful resources are all the appendices from the original document that I referred to. And there are, if you just Google involve consumer participation, you'll find lots of things there. So a couple of concluding thoughts. Certainly, consumer involvement increases the likelihood of patient focus in research, relevant research, and research that is translatable into practice and into policy. And as I suggested, it's relevant to absolutely all areas of health research. But for all of us that are nurses in the audience, we're the people that are seeing and talking to and liaising with our patients on an absolutely daily basis. We can be raising this to a new level of this is something that it becomes the norm, and recruiting people to help us in this sort of activity. It's something that absolutely should be core of everything that we do, given our focus from a nursing practice point of view. Thank you very much.
Well, thank you, Leanne. So we've got time for some questions from the audience. We've got some roving mics there.
Okay, thank you. So wonderful lecture, so great acknowledgement. From your experience, are there any challenges or downsides to consumer involvement?
I guess with anything there's always challenges. The biggest challenges are, in my mind, occur when you haven't planned what you're asking consumers to be and what you want them to help you with. And so having a consumer on a group but them not having a voice is a real challenge. So you do need to make sure that you facilitate that voice. The other thing you need to think about is every consumer has a personal experience. And so they're going to come with that personal experience, and how do you manage that personal experience versus the wider views and opinions and evidence, because it is one part in it. But if you don't manage that process, consumers will feel as if you're not valuing their opinion. So you do need to be thinking and very carefully talking through those differences.
I just wanted to follow that up a bit, I guess, and see from your experience how tightly the experience of the consumer needs to relate to the specific research question. So I think Bob said he was injured in an accident, but would he be useful in a sepsis study in the ICU? And what sort of characteristics do you look for more generally for good consumers that will really value add?
Look, an important point, and it does differ for every single project. So certainly for all our ICU projects, we tend to look for people with ICU experience, but it doesn't matter what brought them into ICU. The sorts of projects I'm looking at are generic across ICU. If you were looking at a sepsis study, then you might want to be more specific. But with something like the Harp doctoral training program, we made no specification of people's experience with health or healthcare. It was any experience with the healthcare service. So it does depend on the type of project. It also is important to think what things do you want them to participate in. So when we advertised for participants or people to help us with Harp, the first thing we needed them to contribute to was the interviews. And because we were a bit rushed, we specified they needed to all be people who had past interview experience. Now, in the long term, that's not what we want, but we were very specific at that point that we wanted that. We also wanted to make sure we had a mix of age, gender, ethnic group. And so we do use demographic forms and ask them to complete all of that and select based on a broad range of those characteristics. And that's not seen as discriminatory or anything like that. That's appropriate in some settings.
Thank you so much for a wonderful talk. What I was a little bit interested in is when you mentioned about the consumers having some involvement in the methodology, and especially about in that particular case was the blinding of a study. And I can understand from a consumer, what you give me what and you don't know what it is. But the flip side of the coin is blinding is there for a really good reason. And then when it comes to actually trying to publish this work, how do you reconcile these, disparate activities?
Yeah, look, it won't always be the case that they should be commenting on that. In that particular case and in that area of research, some of the studies have been done blinded and some haven't. And we had, as a team of investigators, we spent hours discussing this issue, and we could identify reasons for going in both directions. And because we knew this study would be quite hard to get consent in a relevant time frame, we let their opinion on that be quite strong in influencing our decision. But in some other studies, it will absolutely not be relevant or appropriate to have them commenting on blinding of those sorts of things, particularly if it's something that is much more the routine in a field. So it does differ depending on what it is.
So there's a question about budgeting for non-English speaking consumer participants.
Yes. And you should be thinking about that. And none of my studies have ever included it, but I do have some of the researchers in the school where I'm the Associate Dean who do include translation costs for involvement if that's particularly relevant to the question. And that's a great point that's raised. So in the same way you'd think about translation for your participants, you should for consumers as well.
Leanne, there's an emotional burden attached to consumer participation for carers as well as the consumers themselves. How do you go about managing that in terms of the recruitment of the appropriate people and thinking about their experience, especially in the ICU and places like that where there's been trauma involved?
Yeah, so we will think about whether it's the patient or the carer's view or both views that we want involved. The other thing is I am aware of one project that I was involved in peripherally where we did end up actually needing to refer a carer for some care of their own because it's not appropriate for the involvement as a consumer to basically be there debriefing or anything like that. And so we did need to help them find appropriate counselling for their own care as distinct from being involved in research. It is something to be aware of, and it is something to have strategies available to you.
I'll make a bit of a comment because it follows on from the issue of diversity in research. I'm the Deputy Chair of the Consumer Advisory Committee at the Royal Melbourne, and I'm a consumer. And I have been involved more recently in research issues at the hospital from a review point of view and looking at various studies that are going through. And I am very concerned at the very poor participation of diverse communities, even in areas like COVID, where they bore the brunt of a lot of infection. So I think that it's a big challenge, but it is one that people have to take up. And there's also the issue that it actually is a pre-issue because there's an assumption about language, but then there's no test. There's a thing that somebody has to have a certain level of language, but there's no framework in a lot of research studies that actually says, well, how are you going to make that judgment? Are you going to make the judgment because that person doesn't speak English as well as you, or how are you going to make that judgment? So I think it's really, really important that not only that we think about how to engage people who don't speak English, but how do we make really fair, reasonable judgments about who participates and how we engage those communities to actually get that participation. And I think there were some really, really good learnings from COVID about how that can be done via in-reach to those communities. And I think I would really like to see more of that.
Thank you. Thank you for that, and I think you're exactly right. We're only at the tip of the iceberg in many of these things. I will just mention that one of the most active consumer groups in research attached to our school is the mental health group. And people often think that people with long-term chronic mental health conditions, that it's really challenging. And yes, it is really challenging, but they have the most amazingly vibrant consumer group and advise on all of our mental health research in both the trust and the school. And so it can be done, but it requires an awful lot of thought and care and advice from those who are experts in the fields. Thank you.
Thank you, Leanne. Thank you for a wonderful presentation. It's just the tip of the iceberg, really, where we need to move towards, and we've learned a lot from you, and we want to continue our conversation about consumer participation in research throughout this year in our seminar series. So we thank you for the inspiration that you've given us.
Pleasure.
Actually, we're theming our whole seminar series around that. So we've got another seminar coming up, not until August, but our very own Maya Christian Sami will be talking around influencing cancer policy through co-design. So really a nice segue from your brilliant presentation. And we had John Olive earlier this year talking about his work in co-production and photo voice. So it's an absolutely fantastic idea to bring to us at Melbourne and spend some time with us on campus as well at this time. So I'm going to ask Professor Bruce Thompson to come forward and join with me in thanking Leanne and also presenting the Marian Barrett Medal. Thank you. Thank you.